think a really good point. It's as you brought up the term personalized care in terms of actually disease characteristics, but I think that'll also come into account in terms of therapeutic interventions, cost, the scheduling of what type of interventions are required, follow-up that's required, obviously side effects. And just as you said, it's very difficult to compare because the studies themselves were not identical. They tried to get a very similar in terms of disease cohort. So you're not supposed to compare them apples to apples, oranges to oranges. But of course, that's what we do. So as a simple urologist, I just like to look at simple numbers. So if you break down at the 1 year mark, the complete response, you have roughly about 20% with systemic therapy with pembrolizumab, 25, 26% with nadofaragene, with adstiladrin. It bumps up to probably 38, 40% at 1 year with Anktiva, the N803. And then you get a bump up to probably rough back of the envelope calculations to probably about 60% plus at 1 year with TAR-200. Now that's only been, that data hasn't been published. That was what presented at ESMO. So you do see this kind of, again, not fair comparison, but if you lay it out, different delivery mechanisms, different agents, different types of mechanisms of action, but you do see, at least just as you said, Tom, there seems to be less of a drop-off in terms of the response, and that might be due to the continuous delivery. I mean, you've got exposure to the chemotherapy agent, the gemcitabine, basically continuously as you change the pretzel out every 3 weeks. So let's talk a little bit about side effects, and then I want to talk a little bit about kind of intravesical therapy, placement of devices, giving the medicine itself. Looking at the side effects, the systemic side effects with citrilimab are not different from any other immunotherapy. Is that right?
Yeah, it doesn't seem it's not different, and the response rates are not different either.
So yeah, you see basically consistency of, yeah, there's a little signal. There are a few side effects. Nothing that seems to stir the pot too much. When you look at the side effects with the intravesical pretzel agent, Tom, was there anything that stuck out?
No, urologists are fairly comfortable with managing intravesical toxicity. I would say that the pretzel can have slightly a different tox profile than, say, BCG or nadofaragene, because there is something that retains in the bladder, right? And so it's rare, but in addition to the lower urinary tract symptoms that we know about, there are some patients, and it's a small group, but there are some patients that I would say have almost like a stent discomfort type of pain because of the retained agent and the retained body into the bladder. That tends to be rare. You can generally
Are there any strategies that you or your group employ in terms of some of those side effects?
Yeah. So again, remember in the trial, I think it was 6% of patients had to discontinue pretzel only. So again, small numbers, but 6% is still something. Anticholinergics, antispasmodics, topical, pain treatments like Pyridium, alpha blockers for men. Those treatments generally help. I think also what you have to realize, or what you remember about this group, is this is a heavily pretreated group of patients.
Yes.
12 to 15 prior BCG installations, their bladders are beat up, they're inflamed. These patients have sensitive bladders. And so that makes it a little bit more challenging. But, make sure you're ruling out infection. Antispasmodics, alpha blockers has helped us. But I think it does need to be said that there are going to be a small percentage of patients that say, I don't like this right now. And we've actually utilized a technique, I don't know if you can call it, of intermittent just removal of the pretzel. Just give them some time to kind of to wash it out. And then we've had several patients that we've reinserted it in, and they've actually been better. So I think you're going to start seeing some of these strategies emerge. Some patients never say a word about it. They don't even know it's in there. And again, similar to experience with patients with stents, right?
Right.
But we I think we're going to start to identify some strategies to help some of these other patients keep it in. But it is something that needs to be discussed with the patients. I mean, I think the burden of this disease is significant. You know, you talk about catheter installations and patients coming to the office and UTIs and all the stuff that they deal with. You know, my oncology nurse has a little has a little drawing that she gives to patients who get various therapies on what their touch points look like over the next 12 months. Whether it come in for the installation, come in
Share
for the
that with me. I've
cysto.
never seen that.
Yeah,
Come on,
well,
hide the goods.
Well, I credit her. She's terrific. But I think it's important because it's really a quality of life thing. And for a lot of patients that are coming from 100 miles away.
Right. Yeah.
I mean, are you going to have to come, every such, and so with the pretzel, I think it's going to be similar. You're going to have to draw that out and say, you're going to have to come every 3 weeks. We're going to do a cysto here. And so that is going to be a part of this whole discussion as well. How often are the patients? You've mentioned some other agents that have, different dosing strategies. So that I think is important. But overall, we have been involved with quite a few patients on trial across the TAR spectrum, and it's unusual for a patient to have really bad local side effects, but it does happen.